Hi, this is Dr. Bernstein with the October 2018 uh, Teleseminar. Before we begin, I want to give you my usual caveat, namely that the answers I give are guesses. Uh, I can't possibly get the full history, medical history of a patient who asks a question or do a physical exam on a questioning patient, but I could give generalized answers that might be of interest to the listenership in general and may not solve the particular individual problem. First question. Do you feel that some types of MODI, that's maturity onset diabetes of youth, diabetics, can be treated with sulfonylureas? In previous teleseminars, you've shown your concern because of the risk of cardiotoxicity. Well, cardiotoxicity was not my major risk. It was one of the concerns. The major concern is that sulfonylureas have been repeatedly shown to cause apoptosis or beta cell burnout. They seem to work for maybe a year to 4 years, and then they stop working. Well, they stop working not because they're no longer able to work, but because the beta cells aren't there. They've overworked beta cells by pushing them to produce loads of insulin compared to what they're capable of doing, because a diabetic beta cell has limited capability. So they're being overworked and they burn out. So it's a good way, taking sulfonylureas is a good way to convert a type 2 diabetic or a MODI diabetic to a type 1 diabetic. Diabetic for 24 years, using 100 units of insulin daily, which is a large dose. Overweight, 60 years of age, impossible to lose weight following your food plan. Any suggestions? Well, first of all, I'd suggest that you read more of the book, my book, Diabetes Solution, than just the food plan. The food guidelines don't tell you how much to eat overall, which are based in part on are you gaining weight, losing weight, building muscle, etc., and are you hungry? Now, it could be just eating too much. So that's the first thing to look at. Another thing is if you're female and have PCOS, that can cause weight gain even though you're hardly eating. At 60 years of age, I doubt that this is a problem, but it's a possibility. You could be taking a medication or a supplement that raises blood sugar and therefore causes you to take more insulin, and taking a lot of insulin can cause weight gain. I'm not telling you to cut down the insulin if you need it for controlling your blood sugar, though. But if you're taking a medication that raises blood sugar, that's a potential problem. You might also want to check for hypothyroidism, which can cause weight gain. So you should check your free T3 by the methods that we've described on other videos. Also, there's the matter of exercise. If you're sedentary, you might find it easier to lose weight if you exercise more. Also, easier to lower the insulin dose. Do you have an opinion on Victoza versus Ozempic? In particular, whether their safety is equivalent. I've not investigated the safety of these drugs. I do know that the whole category of GLP-1 agonists can cause pancreatitis, and I've seen 3 cases caused by these drugs. Now, the Ozempic is a once-a-week GLP-1 agonist, and Victoza is one that you have to take several times a day. Now, if you read my book, Diabetes Solution, you'll know that I'm strictly using the GLP-1 agonists to control appetite. Their effect upon blood sugar, their direct effect on blood sugar, is very small. One can almost call it trivial. But the effect on overeating, when it works, is considerable. Could have a great effect on your average blood sugar. So if you ask me which of the two drugs, the once a week or the twice a day one, is more effective for overeating, I would say that, in my experience, it's the twice a day one. The once a week one had no effect, and the reason probably relates to the reason many appetite suppressants wear off after a while. You become tolerant of them. And if you're injecting an appetite suppressant that's working all day long, day after day, you're going to become tolerant to it rapidly. Whereas with Victoza, you only take it for special occasions. Many of my patients who overeat between dinner and bedtime will take a shot of Victoza before dinner. It'll start working after dinner, and it'll curb their appetite until bedtime. So I don't recommend the Ozempic from the point of view of appetite control. As far as safety goes, they're both equally safe. The pancreatitis is relatively rare, but it does occur. And the way to find out if you're getting pancreatitis is to, at the first sign of any gastrointestinal disturbance, check for your serum lipase level. You can also check your pancreatic amylase level, and that will make a quick differential diagnosis between pancreatitis and other causes. Next question. Do you have any advice for those of us in the United Kingdom who do not have access to Act Rapid or regular insulin? It's a real problem. Occurs in some countries. You could see if Novolin R or Humulin R are available in the UK, or you could go to a local veterinarian in the UK. They are using regular insulin for animals, and you can buy it for your dog. Tell them you have a diabetic dog, buy the insulin and use it yourself. It differs in no way from human insulin for humans. Another option is to look in the internet at overseas pharmacies, and you'll find pharmacies probably in Canada and other countries that will be willing to send mail regular insulin to you in the United Kingdom. The trouble is that the National Health Service will not be paying for it. It's also possible to get regular insulin through a local physician who has connections with the National Health Service. There are some hospitals, for example, where their diabetes clinic can give you special permission if you give a good enough excuse for using regular insulin instead of the ones that they're currently prescribing. Next question, do you still recommend using Victoza? As I said before, Victoza is a GLP-1 agonist. It's sold to reduce blood sugar, but the effects on blood sugar for type 2 diabetics are very meager. The main effect that I use it for is for controlling appetite. So if it will control your appetite, I recommend it highly. But you do have to be aware of the possibility of causing pancreatitis. So if there are any gastrointestinal disturbances, you have to do the tests that I've already mentioned, amylase and serum lipase. Do you use a Dexcom or similar continuous glucose monitor? Yeah, it's right here on the back of my arm, and I find it of great value. I'm using a Dexcom 5. We're toying with the idea of the Dexcom 6, and we're uncertain with regard to two situations. And this applies also to the other continuous glucose monitors. Can you correct erroneous readings on the Dexcom 6? You can on the 5, because let's say that you end up with a reading that's much higher than your meter, and if you're using an accurate meter, this can set the stage for being high all day long or all week long. So you want to set the Dexcom at the right value. Well, the 5 you can set. I don't have the 6 yet, so I don't know whether you can set it. If you cannot, I wouldn't use the 6. The other thing is the availability of having followers on a cell phone. I have 2 followers who get my blood sugar readings and can get on my back if I don't do anything about low blood sugars. And I think this is of great value, especially for children and for the elderly. So it's unclear to me right now whether you can have followers with Dexcom 6. I don't believe you can have them with the competitive CGMs. Thanks to your diet, I managed to reduce my A1C from 6.4% to 5.6% within 12 months. I also lost 25 pounds, but my total cholesterol went up 60 and my LDL went up, total cholesterol went up to 260 and LDL went up to 175. My HDL is 60. My triglycerides are 122. What would you recommend in this case? Cut out fat? First of all, and I've said this over and over, and I guess this may be a new listener or a new viewer, total cholesterol is not a predictor of heart disease, nor is total LDL. High triglycerides are a good predictor. Low HDL is a good predictor. When someone goes on a low carbohydrate diet, what we find is that the LDL gets transformed from the small, dense, or highly adhesive and potentially toxic LDL to the large, buoyant LDL, which does not stick to arteries. So if you follow a low carbohydrate diet, there's a good chance that your LDL gets transformed to the good LDL. We only measure LDL particle size. I do not measure total LDL because particle size tells you if your LDL is a predictor of heart risk. If it's small and dense, then it's a good predictor. Also, we test for oxidized LDL because that's a good predictor. So if you want to look at oxidized LDL and LDL particle size, then you're looking at something that has a reasonable information. and certainly do not cut down on fat. I'm not advocating that you deliberately go out and eat fat, but fat is not the cause of heart disease. It appears to be carbohydrate. And you get the details on this if you've watched my other videos. Can long-term use of metformin cause dementia? Well, usually doesn't, but it can via one mechanism. Metformin can bind to the intestinal receptors for vitamin B12 and prevent the absorption of vitamin B12. Now, thus far, I've found only one patient where long-term use of metformin caused a reduction in his serum B12. I should say in his whole body B12. And you can test for this. So, a low body B12 can cause dementia. The brain needs B12. So what we do when we put someone on metformin, I get a baseline level initially of serum B12 level, but also homocysteine and methylmalonic acid, because these values go up when you have a low total body B12. So I have one patient who just recently had normal serum B12, normal methylmalonic acid, but his homocysteine has gone up in the year or so that he started metformin. So right off the bat, we're going to prevent the malabsorption of metformin, of B12, by giving him a calcium pill, 1 Tums pill to chew with each metformin tablet. And I might add that we don't give generic metformin, we give the brand glucophage. So if you take these precautions, you don't have to worry about the dementia. My wife is a type 1 diabetic. She struggles with restless leg syndrome and high blood pressure and dehydration, even though she drinks plenty of water. Would you have any suggestions as to tests or treatment to help with dehydration and high blood pressure? Well, first of all, let's look at what are the possible causes of this. One cause of dehydration is a low-salt diet. You're likely to retain less fluid. If she's taking a diuretic, it'll lower her blood pressure, but she can get dehydrated from it. She might have an abnormal adrenal function, an adrenal medullary deficit, and she could see an endocrinologist specializing in the adrenal gland. So I would think that if she's not taking a diuretic, oh, by the way, if she has diarrhea, that can cause dehydration. But if she doesn't have these obvious problems, she should see a reproductive endocrinologist, an adrenal specialist endocrinologist, and he will give her the right tests. To explore this on her own doesn't make sense. So, an adrenal endocrinologist. 42 years old in May. I was diagnosed as a type 2 diabetic. I started at 185 pounds, very fit and lean, and a member of the United States military. I followed your diet. I am now 150 pounds, so he's gone down 35 pounds. Turns out that I have multiple sclerosis. Here's my question. My endo thinks I'm type 1 and my GP thinks I'm type 2. I got tested for antibodies and all tests were within range. Plus my C-peptide and insulin, both in mid-range. Do you think that my MS might be stopping the nerves that controls phase 1 insulin response? I only have phase 2 response. Do you think I'm a type 1? I've never been low. I don't want to stop the diet, but I've lost almost 30 pounds and cannot continue losing at this pace. I've had to double and triple the protein. Nothing seems to help. Well, first of all, if he's diabetic, he might be losing weight because he has high blood sugars and he's spilling glucose into the urine. He's peeing away, that he could be peeing away calories. So he's not mentioned anything about a hemoglobin A1C or blood sugars. So all I can say here is that my guess is that blood sugars are elevated and they're not controlled, and that's why you're losing weight. I suggest also that you read my book, Diabetes Solution. And I'll give you one more tip. I repeatedly said that it doesn't matter what you call the disease that you have, type 1, type 2, MODY, type 1.5. The important thing is to normalize blood sugars, and you do whatever works. And whatever works, you find out by trial and error. Sure, if you can put a name on something, maybe it helps you make an initial guess on what medications you use, but even that doesn't always do the job. For example, I have type 1 diabetics who are taking a variety of type 2 medications. They may be taking GLP-1 agonists to control overeating. They may be taking metformin to control erratic blood sugars the week before menstrual periods. Or I have children with type 1 diabetes who get erratic blood sugars when they're pubescent, and we have them taking metformin, a type 2 medication then. Likewise, I have many type 2 diabetics who are taking insulin. So you should go by what works and not waste time toying with a name. Dr. Bernstein, I've read that when following a low-carb diet, fats should make up 75 to 80% of all calories consumed. Does that seem reasonable to you? Well, no, it doesn't. I don't believe in deliberately pushing fats on people. I think that we should do what our ancestors did. Our ancestors who lived off game, or if they were on the coast, off fish, should eat whatever fat comes with the meat or fish that they're eating. To deliberately seek out fats or vegetable oils and things like that usually causes problems. I've seen a number of new patients who come in on what they call paleo diets, where they're, sure, it's low carbohydrate usually, but they're also cutting way back on protein and eating loads of fat, and they have protein malnutrition. So I certainly don't advocate deliberately going out and pushing fats. I'm a type 1 with little beta cell function. I am under 50 grams of carbo most days. Question. Most days I have 0.5 to 2 blood ketones with blood glucose between 80 and 100. Do I have to worry about hypo episodes because my brain can use the ketones for energy? This is a good question, and when we talk about the classic situation where humans are using ketones for energy, it's when they're starving out in the wild or in wartime, when they're not getting enough food. And when you're starving, you make less insulin. And that's why you start using your own body for nutrition. You start breaking down your body fat and also your body proteins. Whereas diabetics who inject insulin have just the opposite situation. They'll get hypoglycemia from too much insulin. So you're talking about two separate situations. The brain that's existing on no food, the ketones can keep the brain alive, but there's no insulin, or virtually no insulin, so they're not protecting you from hypoglycemia. Don't count on that. I am 37 years old. After 8 months of going vegan, I am having digestive problems and have been diagnosed with chronic pancreatitis. Local doctors are suggesting whole foods and low-fat diet. What's your recommendation? Well, if you have pancreatitis, you want to keep the part of the pancreas that makes enzymes quiet. One of the enzymes that the pancreas makes is lipase, which digests fats. In pancreatitis, the pancreas is leaking enzymes into its own structure rather than into the intestines, and it's self-digesting. So if you eat a lot of fats, it's going to make a lot of lipase and more aggressively digest itself and make the pancreatitis more severe. So absolutely you should have less fats with pancreatitis, but you also should have less carbohydrate in general, and going vegan is really inviting more carbohydrate. Given the overall objective of targeting normal blood sugar levels in diabetes solution, that's my book, I'm curious if type 2s would do this because it's the primary objective or because it's a secondary proxy for the primary goal of minimizing insulin response. Well, the primary goal should be to normalize blood sugars so that you don't develop the long-term consequences of type 2 diabetes. A secondary goal is indeed to preserve beta cell function so that your diabetes will be easy to treat. If you don't preserve beta cell function and lose it over time, you'll eventually become a type 1 diabetic and have to take multiple shots of insulin, and that makes life a lot more complicated. And unless you go to extreme measures, as I do for myself, you're not going to be able to readily control your blood sugars. So you want to do both preserve beta cells, but certainly you want to prevent the long-term complications caused by high blood sugars. I have type 2 diabetes. I'm well controlled When I exercise, my blood sugars go up to 150 to 175, and it takes some time afterwards for it to come down. It feels, okay, he also has apparently, I have peripheral neuropathy in my feet. It feels more numb when my glucose readings are above 110. Is there anything I can do to keep my glucose numbers in check during and after exercise? Yeah, there are several things you could do. And first thing is to read my book, because this question is answered in the book. Number one, you don't exercise during the first 4 hours of the day when the dawn phenomenon is active. There's a good chance that your blood sugars will go up because insulin is being cleared from your bloodstream by the liver at that time of the day. Another possibility is to take rapid-acting glucophage 3 hours before the exercise. That's the brand name for metformin, and there is a rapid-acting one, and it might prevent the blood sugar increase. One thing that I use quite frequently is propranolol. I find that kids tend to have high blood sugars after a game, not after practice, but after a game, due to the emotional increase in stress hormones like epinephrine. And this particular writer probably has high blood sugars because of stress hormones merely caused by the exercise. And if you can block the epinephrine, you might be able to block the blood sugar increase. So you can take 5 or 10 milligrams, usually for an adult 10 milligrams of propranolol, rapid-acting propranolol, 1 to 2 hours before the exercise. That's probably the easiest solution. Another possibility would be to take a small amount of Humalog by injection. By small, I have patients who use diluted Humalog and might take what amounts to an eighth or a tenth of a unit of the undiluted, and they might take that about a half an hour before the exercise. "32-year-old type 1 diabetic woman. I've been diabetic for 15 years. I've been on a low-carb, high-fat, organic, pasture-fed, and greatly nutritious diet for the last 6 months. I eat less than 12 to 15 grams of carbs per day. I've never felt better, and my blood sugar control is much improved. However, my menstrual cycles seem to have gone out of whack. They are getting increasingly longer by the month. The last was 50 days. I am worried that this low-carb, high-fat diet has an effect on hormones. I've spoken, wait. No one I have spoken to is able to explain to me. Could you discuss more about any links between low-carb, high-fat diets and hormonal imbalances? Well, one possibility is if she's only getting 15 grams or 12 grams of carbs a day and she's an adult, she may not be getting enough vegetables and may not be getting enough vitamins. So she may have a deficit of some vitamins that are necessary for the reproductive system. Another possibility is that she may not be getting enough protein. Now, pushing fat is not really logical for any kind of illness that I know of. And estrogen, for example, is indirectly derived biochemically from fat. So it could be that by having too much fat, it might get involved in the production of estrogen. But I think more likely is a vitamin deficit. And in general, I would recommend against high-fat diets and making sure you have adequate protein. And we discuss protein in my book. Next question. A person without diabetes has their blood glucose increased after food intake, or there is a time lag between ingestion and the availability of insulin? Well, it's a good question. There's a time lag between eating, but because of what we call in my book the Chinese restaurant effect, and is now more scientifically called the incretin effect, even before food gets converted to glucose, the body starts making insulin. So for a non-diabetic, insulin actually gets a jump on the food. And this, I believe, is discussed in my book. Recently, my supposedly diabetic 9-year-old son wanted to take a home A1C test, and I did one. My results were higher than my usual. 5.8 is my usual. But my son's results came out much higher, 6.5. My husband and mother also did one, also with high results, 6.1 and 6.8. We then did various finger pricks and found his fasting numbers are around 95 to 110, with spikes from 120 to 220 after meals, depending on carb content. What would you recommend as the next steps in terms of testing blood work? Neither of us have any symptoms of diabetes at this point. Well, first of all, I would make sure that you have an accurate meter for doing the blood tests. And we recommend the Freestyle Freedom or the Freedom Light. Then I would recommend that you not use a take-home A1C test, because we've found major errors in the ones we've tested. That you go to the doctor, get your blood drawn, and see what a clinical laboratory A1C test looks like. And if it turns out that any of you are diabetic, you should follow my book, Diabetes Solution. Type 1 diabetic. And as someone else also diagnosed with lupus, I'm curious about your view on prednisone and diabetes. Well, prednisone will certainly raise blood sugar. I have a formula that I use and that I've disclosed on my teleseminars for how much regular insulin to inject for every prednisone dose, and the amount of regular is based on the size of the prednisone dose, and it does vary from one person to another, so it's really a guesstimate, and then you adjust the amount of insulin in the future if you're running, if your blood sugars run too low or too high after the shot. Now, there are other treatments for lupus beside prednisone. For example, there are biologicals, which are antibodies to certain inflammatory cells, and there's at least one anti-malarial drug that's used to treat lupus. So make sure that that your physician is a specialist in lupus. I know that in your opinion, regular human insulin bolus, Act Rapid, where I live, has its advantages when on a low-carb, high-protein diet. But what about basal human insulin, insulutard? Are newer insulins, for example, Tresiba, just plain better? Well, insulutard is NPH insulin, which is not a basal insulin. It's an intermediate acting insulin. I've only used NPH insulin for two situations. One situation is in infants where they need diluted insulin, and you cannot dilute any of the current long-acting insulins. So what we do is we'll give them diluted NPH insulin maybe 4 to 6 times a day to serve as basal insulin. The one other situation where I might use NPH insulin is for people with gastroparesis. In certain situations, you might want to slow down the regular insulin that they inject for their meals. And we might add a small amount of NPH insulin to the vial of regular insulin to slow it down, and sometimes this works. The trouble with gastroparesis is that it's not predictable. So it's more important to treat the stomach emptying problem first before you address the insulin problem. How do you gain weight and still eat low carb? I am diabetic type 2 and have lost too much weight. A1C is 7. At an A1C, after eating more, I get an A1C of 8.2 and feel terrible. Doctor upped my metformin, very frustrated. So what I would suggest is that you eat more protein and that you cover it with insulin and keep your blood sugars normal. Certainly with an A1C of 8, that's an average blood sugar of about 220. You're spilling glucose into the urine, so you're literally losing body muscle mass. You're peeing it away, and it looks like you'd probably do better with insulin. How much insulin do you take per day? I take about 19 units per day, and it's less in the summertime. Where I am, it's now winter. Right. I am a normal weight female, 34 years old, considered a mild type 2 diabetic that began as gestational diabetes. Metformin, 2,000 milligrams, works very well for me now that I follow your diet. I would like to plan another pregnancy without complications. My last pregnancy I took glyburide and ended up with an 11-pound baby who spent days with low blood sugar. What dose of metformin is safe in pregnancy? If that is not effective, should I ask for insulin instead of glyburide? First of all, glyburide is a sulfonylurea. It is difficult to titrate blood sugars with glyburide. It can cause beta cell burnout and could possibly be the reason why you developed type 2 diabetes after your pregnancy. So I certainly wouldn't take that. Metformin has been tested and found to be okay in animals, but there haven't been any human studies. So it's the job of you and your physician to decide whether you want to consider metformin. Chances are that you need insulin, but if you do need insulin, you have to know how to use it properly, and that's where my book, Diabetes Solution, comes in. I'm a type 1 diabetic for 40 years. I currently wear a Dexcom 5. My last A1C was 5.9. That's an average blood sugar of around 136. My endocrinologist is trying to convince me to add on the Dexcom 6 insulin pump. I'm concerned that the technology is still nowhere where it needs to be. Appreciate your opinion. Well, first of all, read my book, Diabetes Solution. There are many reasons not to use an insulin pump. They're all detailed in the book. And it's not just a matter of algorithms for the pump, that somehow, someday, they're going to have the right software and algorithms for the pump to normalize your blood sugars. Part of the problems with the Dexcom or any continuous glucose monitor is that they are not really measuring blood sugar. They're measuring glucose in the interstitial fluid between the cells, and this is not exactly the same as blood sugar, but also it runs 20 minutes to a half an hour, most usually a half an hour behind blood sugar. So the Dexcom is always behind, and injecting insulin subcutaneously is even further behind your blood sugar. So there are many reasons why this cannot possibly work. On top of that is the scar tissue caused by the insulin pumps, which after a few years makes it impossible to know how much insulin you're actually absorbing. I'm hearing a lot about healthy fats like medium chain triglycerides as oil, but I'm concerned about the cardiovascular impact of increasing fat. You have any thoughts on this? Well, I haven't seen any evidence supporting pushing large amounts of any kind of fat, including medium chain triglycerides. I don't know of any cardiac benefit. There is benefit in low carbohydrate diets. Eating a lot of fat will make you feel full, so you might lose some weight, but if you feel full, you won't eat enough protein. So you're asking for protein malnutrition. If you want to have a teaspoon of medium chain triglycerides a day, I don't think that'll do any harm. But pushing it in quantity would be a big mistake. I've been a type 2 diabetic for 34 years. I've been on every medication known to man. I recently started intermediate fasting, and now I want to start on your diet, and I'm worried about ketosis. How long can your body be in ketosis? Oh boy. Well, first of all, if you look at people who survive a war or a famine, they could be in ketosis for months or years. Ketosis per se is not a problem unless you get something like diabetic ketoacidosis, which involves very high blood sugars and severe dehydration. So I've been on a low carbohydrate diet for 45 years now. I'm 84 years old, and I never check my blood for ketones. Having ketones in your blood is part of humanity. It certainly is not adversely affecting me, nor my patients. I've lost 60 pounds and reduced A1C from 14.2 to 5.9, eating a low-carb diet, and only eating between 10 a.m. and 6 p.m. I stopped taking Invokana, which is an SGL2 inhibitor that causes you to pee excess glucose into your urine. I stopped taking Invokana many months ago, and my doctor stopped metformin 2 months ago. But now my fasting number is up to the 120s, and I have to walk at least 3 miles to get my numbers under 100 at all. I have no problems with metformin if my next A1C is up again. How can I convince my doctor to prescribe metformin again? Ask him why he stopped it. And you can search on the internet for scientific articles about the use of metformin for non-diabetics to increase lifespan. So metformin is not a harmful agent, as some of the oral agents are, and it was at one time looked on as the fountain of youth, and that everyone should be taking it. So you can show him these articles. There's a lot out there, and ask him why he wants you off the metformin. Diagnosed at age 17, now 26. How do I increase muscle mass? Well, first of all, you need normal blood sugars. That's absolutely essential. Second, you need to exercise. And if you're exercising, you need much more dietary protein than if you're not exercising. Now, I have formulas that I use for guessing at how much dietary protein an exercising person will need, but you do this by trial and error. You go to the gym, you work out an exercise routine, and maybe you double the amount of protein you're eating, see how you feel. If you're feeling too full after a meal, you might want to cut it back a little, and it's all trial and error. You also, if you want to increase muscle mass, should check your serum free T3, because if you're hypothyroid, you're going to have difficulty building muscle. Hypothyroidism tends to lead to muscle breakdown. So that really is about it. Next question. I'm a 65-year-old male, type 2 diabetic of 25 years, using Tresiba, Humalog, and metformin. I've tried your diet plan and strictly ate the 6-12-12 carb recommendation. My fasting blood sugar values continually keep rising, however, sending glucose values out of control. Will switching to Humulin R for bolus correct the problem? Well, first of all, if you're suddenly getting higher blood sugars, I would worry about infection. And in my book, we warn you, if you can't see any signs of symptomatic of infection, no urinary burning, no cough, cold, skin abscess, we suggest that you visit your dentist, and we tell you in the book what you should ask the dentist to look for. If your fasting blood sugar is elevated, you may need, well, you're already taking Tresiba, but maybe it's not enough. I'd say you look at the book, and it has a whole regimen for you to follow that may be much different, even though it might be recommending the same insulins. It might be a lot different than what you're doing. But I would certainly want to rule out the possibility of infection, especially in the mouth. In an article by Francesco Rubino, he spoke about a surgical treatment for type 2 diabetes. He claims that shortening the length of the upper intestines has more effect on diabetes than any other existing therapy. He states that over 40 medical organizations recommend this option, and that 80% of the surgery patients with diabetes were not taking insulin 5 years after their surgery. Are you aware of this method, and what is your opinion? Yeah, the method facilitates weight loss, facilitates less blood sugar effect from food because you're absorbing less carbohydrate and other nutrients from food. And indeed, they found that it does frequently reverse the type 2 diabetes. And the method by which the means by which this is accomplished seems to be mysterious and is being studied continually. However, I imagine that this author did not mention that there are a lot of long-term adverse effects that have been reported, and it would certainly seem to me that a proper treatment would be to stop the overeating rather than removing parts of the intestine. And we've been pretty successful in stopping overeating. I think I've had 2 patients who are planning either gastric or intestinal bypass procedures, and both of them lost large amounts of weight just by controlling their overeating, which isn't easy for many people, and many tricks are needed. Not sure I understand the ratio of units of insulin to grams or ounces of protein. Is there a simple rule of thumb you can provide? Yes, but it's not going to work for everyone. If you're a total type 1 diabetic, I find that usually a half unit of regular insulin covers 1 ounce of protein. This might not work for type 2 diabetics. First of all, because they're making insulin and may not need as much, or it could be because they're insulin resistant and need more. So this is a rough rule of thumb. You have to try it out and see if it works. It's not guaranteed, but that's what I use as a starting dose for my patients, and then we adjust it from that point on. "61-year-old female, diagnosed type 1 8 months ago, injecting 3 units of levemir on arising and 2 units of levemir at bedtime. Gastroparesis, following your diet. Should I be doing bolus shots? Gastroparesis makes the timing hard. How do I do this so I can totally normalize my blood sugars?" Well, it's all detailed in the book. It's so complicated to deal with gastroparesis that we have a whole chapter on it in the book. What's interesting is that she was diagnosed type 1 only 8 months ago, and she has gastroparesis. Well, it takes years to develop severe enough autonomic neuropathy to cause significant gastroparesis. So something right off the bat is strange about this. If she's been living with undiagnosed diabetes for years, she may have many other complications. But anyway, the book deals with gastroparesis in great detail. "My 13-year-old daughter was diagnosed with type 1 in February. She is of normal weight and height, and her last A1C was 6.4. That's around an average blood sugar of 156. She recently started following an extremely low-carb diet. At first, her blood sugar levels were low and predictable, but then, without any change in diet, became high and unpredictable. 200 grams of fillet of steak and a side salad was requiring 5+ units of Humalog. Her endocrinologist said the low-carb diet was making her insulin resistant and said she must up her carbs to 90 grams per day. Please give me your take on this." Well, it sounds like she probably had beta cell burnout, which could occur when you have high blood sugars, and an average blood sugar of 156 is certainly high enough to facilitate beta cell burnout. But another possibility is her age. She's 13 years old, and when kids start making growth hormones and are pubescent, they become insulin resistant. And I actually anticipate this in advance. If I have a child who's 10 years old, I usually don't do anything, but by the time they're 12, even if it's a girl and she hasn't had periods yet, I'll start her on metformin, on glucophage. So I have a lot of pubescent kids on glucophage. And how do you convince your doctor? I don't know. You might want to find a kindly pediatrician who will listen to reason. We've had, every month we get many questions about problems with endocrinologists who want high carbohydrate, high blood sugars and so on. But my guess is pubescence, but also there's the fact that high blood sugars do facilitate beta cell burnout. My husband is a type 1 diabetic with severe gastroparesis since 2005. He sees an endocrinologist who previously helped in this area, but they actually don't seem that concerned that he has been hospitalized over 80 times for gastroparesis vomiting. Well, again, my book is a whole chapter on gastroparesis. By the way, we found that there is a pharmacy in Vancouver that you could find on the internet who will ship domperidone to the USA. This is a medication that is used to curb gastroparesis. It's one of the drugs that we mention in my book. Well, that's it for October. Our next teleseminar will be Wednesday, November 28th. Look forward to seeing you then. Thanks for listening.